we shrink the panel to 400 to 450. And we make the panel size manageable enough that that doctor can have deep relationships that are built upon trust. Now, once you connect a talented, caring physician with a small panel of patients, beautiful things happen.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today we have Dr. Gordon Chen. He's the Chief Medical Officer of ChenMed, a physician-led primary care practice whose goal is to deliver affordable care and superior experience to seniors across the United States. ChenMed offers a very, very unique value-based healthcare delivery system. Welcome to the podcast, Gordon.
Thank you so much for having me, Bob.
I got to tell you, I've been looking forward to having this interview with you for several months now. And I first was introduced to you through a book that I was reading, and it was The Long Fix by Dr. Vivian Lee.
Yes.
And she featured what you guys are doing with ChenMed. And I said, that's exactly the kind of stuff that we're trying to teach our physician leaders at our program here at UT Dallas, and also in our healthcare professionals class, the exact same type of things. So today I want to hear about the Chen family story and what you're doing and what makes you guys so very, very unique.
All right. Well, it's so good to be with you, Bob, and I look forward to sharing our family story with you. I may get a little personal, right? You know, we're talking about my family, and I hope that you guys get to know us a little bit better. So unlike healthcare organizations that really are birthed out of private equity or venture capital, and they're created to generate a return, right? ChenMed was born out of suffering, and here's what I mean, all right? So we have this mission to really help seniors in poor, forgotten, impoverished communities to avoid the suffering that we had. As a family full of doctors, our suffering started around 17 years ago. We had a CT scan from my dad that revealed a 5-centimeter golf ball sized mass behind his nose. Just think about that. Like, whoa, a golf ball behind your nose that's growing, right? And he was told that he had less than 2 months to live. Now, as someone in his mid-50s, that was a shock to him and to our whole family. And as we came to grips with my dad's diagnosis, we struggled to think, how are we going to navigate through the healthcare system? How are we going to make his remaining days count? We had all this medical training, we had connections in the field, we had resources, and we recognized that so much of what we had devoted our lives to in healthcare was a broken system that was working against us. Dad was really at the mercy of a system that was built upon sick care and burnt out doctors and incentivized all the wrong things. And we felt hopeless and vulnerable. And we also related it back to our patients. We thought there's no way that seniors, either that we were taking care of or across the country, would be able to survive something similar. Now, Bob, there is a happy ending, all right? By God's mercy and grace, Dad is now cured, and let me tell you how that happened, okay? So thinking about the 2 months to live and that prognosis, I was engaged at that time to be married. And so to ensure that my dad could be at our wedding, with his face, literally, we had a 24-hour wedding, right? And we called all of our friends and family, and we just, all right, whoever can get there, let's get there. And as I'm waiting for my beautiful bride to walk down the aisle, my dad gets a call from his pathologist, a second opinion. And the pathologist said, I think the diagnosis is wrong. I don't think it's a carcinoma. I think it's a lymphoma, a large B-cell lymphoma, which means it's potentially curable without surgery, right? And you can imagine I'm waiting for my future wife to walk down the aisle. We set up this emergency 24-hour wedding, and we get the news that he's got a chance, And that was the best wedding present that I could have gotten. I mean, that was just amazing.
Gordon, you say a family of doctors. Your father was a physician and your brother's a physician?
That's right. My father practices internal medicine. My brother and I are trained in internal medicine and cardiology. And my wife, we met in medical school, right? She's an internist as well. And so we found it just so eye-opening to be a family full of doctors, but then to also be in the role of a patient that's vulnerable, that's fighting for days or months. And although the diagnosis was wrong and there was a happy ending, we suffered. And so Dad had complications. He had 6 rounds of chemotherapy, multiple cycles of radiation, and he suffered a mini stroke. He had a blood clot. He had a neutropenic fever, emergency room visits, right? And so we really got to experience so many different aspects of how our patients suffer. And that suffering really defined the birth of ChenMed because it created this burning desire to make things right. Understanding the physician perspective, the patient perspective, and then understanding the great need there is out there to fix this broken system. That's when we as a family said, we have to work together to design a better system for the thousands and thousands of patients that are out there really suffering through this broken system.
Wow, that's a compelling story, Gordon. And I can tell you, I've interviewed a number of people, and quite often there's a personal event in their lives that basically redirects their entire outlook on what they do and who they are and how they serve others. And that sounds like the very basis of what happened here with ChenMed to get it up and going. So I want to learn more about what you are doing and how you are doing it and the success factor. This is a business that you've grown, and I want to hear about the growth and the ways that you've gone about making this a viable going concern.
For us, we are built upon a full risk value-based care model. We focus on seniors, and because our seniors have Medicare Advantage plans, that allows us the flexibility to think more broadly in whatever ways that we can help seniors achieve better health. And so immediately we go right to that relationship between a physician and their patients. And so instead of 2,300 patients to one PCP, which is really, it's very difficult to manage, right? It's no wonder why so many PCPs are burning out. We shrink the panel to 400 to 450. And we make the panel size manageable enough that that doctor can have deep relationships that are built upon trust. Now, once you connect a talented, caring physician with a small panel of patients, beautiful things happen, right? They're connecting frequently. Our physicians are really acting as health coaches. They're helping patients to set goals and achieve higher levels of health wherever they are. Now, they happen to be taking care of really, old, poor, sick patients, multiple chronic conditions. And it takes probably months to get them tuned up from a medical standpoint, but it doesn't stop there. Then they think about how they can get to know their family, their social support, how they can set even higher goals like, how to lose weight, how to get off medications, how to get off insulin, right? And so they continue to take the ball and move it forward. And it doesn't stop just when you reach that status quo of whatever that, you're no longer quote unquote sick. No, we continue to push the bar on health forward for our patients. And that's why we've been able to achieve the outcomes that we have. And so we've been able to reduce hospitalization rates by 30 to 50% in a predictable manner, whichever markets that we enter. And we were able to just publish a study that came out in the American Journal of Preventive Cardiology showing that with our high touch care model, even throughout coronavirus, we can decrease mortality by about 40% in patients that get coronavirus, which is just a testament to the doctors that we have and the care model.
So your primary care physicians, your PCPs, they have a panel of around 450 patients. That is it, as compared to several thousand patients. You mentioned that in this situation, you're at full risk. For the benefit of our audience, tell us what that means and how that got started and how that affects what you do.
Sure thing, Bob. So full risk means that we are fully accountable for all of the healthcare costs related to that patient. And so as a group of physicians and primary care champions, we can look at patients and say, how do we get them to better health? And let's not set any boundaries on what we think we can do for them. So in a traditional, let's call it fee-for-service model, they're only focused on those primary care encounters, and they're only reimbursed by generating more of those encounters. In our model, we can think broadly and say, whatever it takes to help our patients to achieve better health, to build relationships with them, to deliver amazing service, if we can prevent hospitalizations, then we can reallocate the dollars that would have gone to pay for ER visits or the hospital, and we can invest it upstream into primary care. That's how we're able to invest in our doctors to shrink the panel size. We invest in things like transportation for our patients, or medication that can be delivered to the patient right on site or delivered to their home. We can afford these frequent visits. We can afford the accessibility to our PCPs. And so these patients are getting this VIP concierge level access to doctors, but they're not having to pay the extra fees, right? Because most of the Medicare Advantage plans have $0 premium. So it's this beautiful environment where you can be taking care of some of the neediest, poorest patients and give them just amazing VIP care. And it's just something that I think warms our heart and gets us excited to take care of them and serve more seniors.
You know, if you try to call up a doctor today, and I'm not saying this in a disparaging way, it's just the reality that it's very difficult to get through the system of choose one for this, choose three for that, go down the phone menu, if you will, and then you end up getting a voice recording, and then you end up hoping that someone's going to call you back. In your environment, I heard somebody mention that your primary care physicians, they actually see every patient in some form or fashion once a month, and you've got things that are called love calls. What is that all about?
So love calls were birthed out of this coronavirus pandemic. So the general approach of our model is not transactional. It's more about relationship building. And so we'd like our physicians to connect with their patients at least once a month, right? And to build that relationship, to really invest in getting to know each other, because it all starts with trust, right? And so if they're building trusting relationships between the doctor and their patients, beautiful things happen. The pandemic really shifted our approach dramatically in terms of, instead of seeing patients in person, we knew that we were potentially putting them at risk by having them, come see us in person before we had a better understanding of how to protect ourselves from coronavirus. So we shifted to telehealth. Over 90% telehealth visits in about a week. We're able to pivot that quickly and not worry about reimbursement, just saying whatever it takes to take care of our patients. But then the other thing that we noticed is our patients, they were so vulnerable, we needed to really aggressively educate them on what they can do to protect themselves. And so we said, we're going to make love calls to our patient. And that means that every week we're going to call our patients between doctors and their care team and staff. And we're going to educate them to be socially distanced, to wash your hands, to use masks. We provided patients with masks. The other thing is, with these love calls, we were not only taking care of their medical needs, we were looking out for whatever needs that they had, right? And so we had patients that were terrified to leave their homes, and they didn't have food. Literally, we had patients without food or without toilet paper. We said, listen, we are there to serve them. We're going to go out and buy them food or toilet paper and deliver it for them so that they don't have to leave their homes. And so we did all of these things through love calls, identifying their needs proactively. And I believe it's earned a tremendous amount of trust with our patients and saved thousands of lives, right? We're in this environment where we're taking care of literally the most vulnerable patients that coronavirus could impact, right? Multiple chronic conditions, minorities as well. Most of our patients are African American or Hispanic, and they're seniors. And so you could imagine, as Chief Medical Officer, I'm thinking about how do I protect our patients and empower our teams. And so what we did is we literally just empowered our clinicians and our local leaders in their communities to say, do whatever it takes, even if you have to go off script, right? Whatever it takes to protect our patients during this time.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Well, I opened up this conversation by saying you have a very unique value-based healthcare delivery system. And as I start to look at that and evaluate that, the whole concept of fee-for-service, that's been the traditional way that, primary care doctors have operated. And I know that in COVID-19, the fee-for-service revenue has gone down tremendously. And you're doing a lot of telehealth, but there's no fee-for-service at all in what you do, is there?
That's right, Bob. We don't have fee-for-service. We are completely dedicated to this value-based care model. And it starts with this philosophy that you cannot practice schizophrenic medicine. So in other words, you cannot have an approach where one part of the business is trying to improve outcomes and build relationships and trust, and another part of the business where it's purely transactional and about billing, right? Or about procedures or whatever it may be, right? And so we said, listen, we need to just focus on what we know works. We want to be a relationship-based organization that focuses on delivering better outcomes for our patients. And so we're all in value-based care. And I'll tell you what, Bob, that becomes so much of a blessing because it becomes so much easier to decide how we take care of patients, in which way, how do we take care of each other, the team members as well. And we don't have to worry about, if the volume shuts off because of coronavirus, then our revenue stream stops. Being in a full risk model, our revenue stream had been protected for the whole year already. So that really empowered us. It gave us tremendous flexibility to meet our patients where their needs were, even through a pandemic. And I think what it's done, and I'm going to be bold with saying this, I think it's really signaled the end of fee-for-service primary care, because it's just not going to be sustainable for fee-for-service primary care to continue to compete when it's so threatened by just being dependent upon transactions. And more of healthcare is shifting to value, and there's bipartisan support for value-based care. This has really accelerated our growth. And so we see the demand kind of going up exponentially for what we can do for patients.
Well, there's a real victory here with value over volume, it sounds like. And I'd like to talk a little bit about your business model, because this is the business of healthcare. And currently, you have 60 different centers in 10 states. Is that true?
Yeah, so we're in the middle of opening centers. So we're close to 76 centers in 10 states. We're opening 25 to 35 centers in different communities across the country. And we're expanding to 2 additional states. We're hoping to expand to additional 40 to 50 communities. And, Bob, what's interesting is our motivation for growth, I think, is important to explain here. We have this model that can literally reduce hospitalizations 30 to 50% in the most vulnerable patients. If we know that we have a model that can do that, and that there are patients suffering and literally dying early, we believe that our model can help patients live about 5 years longer. Then, as leaders in the organization, we feel this moral imperative to grow. And so we're going to try to grow as fast as we can while maintaining a great, strong culture and while focusing on outcomes. Now, here's a beautiful thing, right? As I look back over the last couple of years, we've grown tremendously. And we've actually improved our outcomes along the way. And we had very good outcomes to begin with, but we're able to continue to improve. And so what's happening is we're able to invest in technology, in predictive analytics, and AI, and we're getting smarter as we grow. And so if we're in a situation where even now our outcomes are strong and we want to get the model out, and as we grow, we can continue to improve our outcomes further through improvements in operations, in analytics, in technology, and data, then we want to grow as fast as we can grow in a responsible manner.
You know, it's interesting, Gordon, as you speak about your growth. Obviously, the model's working. Today, Optum, they have the largest base of employed physicians, something like 35,000, a huge number. And they're buying up these smaller groups. And you've got the private equity groups out there that are trying to round up and consolidate, the primary care physicians as well. My biggest fear is that in a situation like you describe, with what you're doing at ChenMed, is that some private equity group comes in and says, hey, you guys did pretty good. Here's the big check, and then this greatness goes away and you no longer have all these, VIP treatment centers, so to speak, and you're back to the old, the big machine again. So how do you guys stay away from an exit scenario like that? It's got to be part of your philosophy.
Thanks for bringing that up. We've seen a lot of groups get bought out by private equity or by big, health plans. If I can open up and be transparent with our family purpose, is to glorify God by spreading more love and promoting better health in all who come to contact with ChenMed. And we've been very focused on serving others and even medical missions. We've been going to Nicaragua for over 20 years, and we'll even take teams from ChenMed. This is pre-COVID. We would go twice a year, bring teams to really serve the poor in the communities there. And we don't think that we need to necessarily go to Nicaragua to serve, old, poor, sick people. We can do it right here in America. And so we have this view of what we do here really as a ministry. Okay. And so if we're viewing it as a ministry, then why on earth would we try to go away from what we feel like we're called to, right? In fact, the need is so great, we need to devote more of our time and effort focusing on how we can get the model out to the communities that need it. So that's one part of it. It's just, our family purpose and really being mission driven. And I believe that we have the most mission driven physicians and team members in healthcare today. On the other side of things, we talked about growth, and we're in this very blessed situation where we've been able to go into needy communities, heal them, be on this value-based care platform where once we can really start to heal the communities, lower the medical costs, which we can lower medical costs by 20 to 30%, then we can reinvest those savings back where? Into future communities. We invest those savings back into future communities. Well, that means that we're not dependent upon, Wall Street or private equity or venture capital to say, hey, I need a return. So our return is being good stewards and creating more health and living out our vision, our mission, our purpose. And that's where we get excitement from. And so not having to be dependent upon external sources of funding, I think has been a tremendous blessing. So we're trying to figure out that right balance between growing as fast as we can because we have a moral imperative to get the model out, but not being dependent upon external sources of funding that could degrade our mission orientation. And so thank God we've been able to steer clear from some of those changes in focus. Okay.
So Medicare Advantage it's the new future. I think everybody recognizes that. Obviously, there's a huge population growth in the Medicare field, and Medicare Advantage plans are becoming more and more attractive. The government can't sustain taking care of everybody with just the ordinary Medicare, I think. These Medicare Advantage plans, what do they look for when they look for provider groups? I would think that if it was a beauty contest, you guys would be getting all the praise along that line.
We're very fortunate to have great relationships with our Medicare Advantage plans. We take over 20 plans. We obviously focus on a smaller group of plans that we have more of our membership in, and they consistently tell us time and time again we are their top performing provider group, and it's not even close. It's by far. And I think it's because of a few things. One is the mission drive, the doing what's right for the patient, that internal motivation. It leads to success in a full risk model because going the extra mile for patients lowers unnecessary utilization and visits to the ER or to the hospital. Like if I'm picking up the phone when no one else would for a patient and it prevents them from going to the ER and getting admitted, I'm saving their life potentially, and I'm also reducing costs just by building upon those great trusting relationships. And so Medicare Advantage plans, they love the fact that we focus on outcomes. We are very good stewards of our healthcare resources. We don't like to waste it all, right? Because we know that if we're wasteful, there are other communities that we can't go into if we're not taking care of our healthcare dollars well, right? They also know that we are very operationally oriented. So, from a stars or quality HEDIS standpoint, we tend to have the best marks in all of those quality indicators because we're just focused, right? We're focused on seniors and we're focused on value-based care. We don't have to spread our time with fee-for-service or take care of other populations. So whenever you focus, you can perform better.
We've all been educated that the most significant part of healthcare isn't necessarily seeing the doctor, but there's so many of these social determinants of healthcare.
That's right.
And the things that you're doing that really engage in the person's health life, I think that's a unique difference. So these advantage plans, these Medicare Advantage plans, when you keep people healthy, you make them more profitable, I guess, right?
Yeah, we make the plans certainly a good amount of profit. And we know that, but you know what? It's great. We want them to win too. We want this to be win-win-win for patients, for doctors, for plans, for the communities. That's how it's going to spread. We need to be an agent that helps communities, plans, patients, doctors win. And I think that this is a platform that everyone can win. It's really important.
Okay, so as you're building out these centers across the United States, you're not from coast to coast yet, but I have a vision that I think you will be at some point in time. What type of technology have you used? There's a lot of technological innovation taking place now, and there's a lot of disruptors, the Internet of Things and blockchain and artificial intelligence and all these EMR systems, electronic medical systems. What have you guys done along that line? Do you innovate yourself or do you use standard off-the-shelf things? What's your business development plan there?
So probably about 2 decades ago, we made the critical decision to say that we need to invest in our own technology. The reason is because most of healthcare is fee-for-service, so the technology will serve fee-for-service business, and it won't necessarily serve a full risk value-based care model that's around, relationship building, connection, coordination, cost management, all of these things. And so we invested long ago, and so we have our own technology arm, we call it CTech here, and we built our own EHR, electronic health record system, and practice management system as well. And so the amazing thing is the data is out there. There's plenty of data, right? Healthcare is not short of data. What it's short of is physicians that want data to help them manage their patients in a better, more cost-effective way. Fee-for-service does not incentivize that. So although the data and the technology may be there in the fancier systems, they're not being used. In our system, we can develop our own technology, and this is how we can iterate and improve the model. And so the technology and the data empowers our physicians and our care teams to deliver better outcomes for their patients. So there's a key difference there. And we're going to continue to double down on technology. I believe that we have some of the best leaders in healthcare technology in the country. We're going to continue to attract healthcare IT leaders that want to really truly make a difference in terms of outcomes orientation for their patients. And so I think that that's going to be a strength for us in the future and now.
So recruiting the next generation of primary care physicians, people coming from fee-for-service into a value-based environment, what does your culture dictate in the types of docs that you recruit into your environment?
That's a great question, Bob. So much of what we do is so different than fee-for-service primary care. And in fact, it's so different that we need to train physicians in how to be successful in a full risk value-based care environment. That starts with leadership training and really teaching physicians how to influence, how to build relationships, how to connect. And so all of our physicians that we're able to recruit in, they need a really high level of humility. We call it learning humility and learning agility, right?
I like it.
They need both of those things because it's almost like a fellowship in value-based care for them.
Repeat those again for me.
Oh, learning agility and learning humility.
I like it.
So if we have a physician that says, hey, don't teach me anything, I have it all figured out. Well, probably not a good fit for ChenMed, right? Because we're a learning organization. And then the number one thing that we have to go for, even if you have learning agility, learning humility, you need the alignment with our mission, vision, and values. Because we're such a mission-driven organization. It's so much of who we are. So it starts with that mission alignment. You need to have the why correct first, right? You need to really care for patients, and you need to have empathy for them and their suffering. And then if you have the learning agility and learning humility, wow, we can teach them. We can teach them. So they go through 9 to 12 months of what we call black belt training. And it took us about 2 to 3 years to set up this curriculum. We had all of our clinical leaders across the organization. We took our ChenMed partners, the masters of this model. We said, what do we need to do to help to create an opportunity and an experience for physicians to learn these leadership skills that they were never taught in medical school or training? And it's simple things, right? Like, how do you set goals with your patient? Or how do you have discussions on changing patients' behavior? So we go deep into motivational interview. How do you coach patients on lifestyle? My background is internal medicine, cardiology. I had maybe one class on nutrition, right? And I believe with the right diet, you can probably prevent the majority of cardiovascular disease if you had like a whole food, plant-based diet, And so we have to teach our physicians this. So we give them education on lifestyle and encouraging patients to improve their activity. And so the purview of our doctors is not just medical care. It's anything that impacts health, which includes understanding the social and behavioral determinants of health. And that's about 60% of the answer. I think that the traditional medical care is probably 20% or less of the answer. The majority of it is in the social and behavioral determinants of health. And that's where we really focus on equipping our doctors to be able to influence.
Well, we've enjoyed it today, and we'll be glad to share this podcast with any other information that you have related to what you're doing. So it's been a great pleasure to have you today, and we're going to stay in touch with you here, Gordon, and follow you and have you back on another podcast in the future.
I look forward to it, Bob. Thank you so much for having me. May God bless you.
Thank you.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.